Okay, let's dive right into this explainer and establish the critical, life-saving medical safety thresholds in the delivery room. When we talk about childbirth, we naturally focus on the joy of the outcome. But the reality of the delivery room is that it can become a high-stakes clinical environment and an absolute heartbeat. Today, we're looking at operative vaginal birth, specifically vacuum-assisted delivery. We're going to unpack the hard data, the clinical protocols, and those absolute limits that medical professionals literally have to navigate to keep both mother and child safe. It's a profound tension, right? In a complicated delivery, how many vacuum attempts are simply too many? On one hand, you have a physician urgently trying to aid a stalled labor, doing everything they can to assist the mother and deliver that baby safely. But on the other hand, pushing past certain physiological limits can unintentionally cause severe, irreversible harm. Finding that exact threshold, that razor-thin line between a helpful intervention and a dangerous one, is exactly what we're exploring today.
Now, you might expect a medical textbook to give you one universal, mathematically perfect number for when to stop. But major professional clinical bodies, like the American College of Obstetricians and Gynecologists, well, they emphasize continuous clinical reassessment rather than a single rigid limit. And that makes sense, right? Because every mother, every baby, and every delivery is entirely unique. Progress has to be constantly evaluated in real time. So no, there isn't just one universally mandated number that applies to every single hospital on Earth. But, as we're about to see, that absolutely does not mean there are no rules.
So here is our roadmap for today. 1. The guidelines. 2. The absolute limits. 3. The medical risks. 4. The sequential danger. And 5. Knowing when to stop.
Section 1. The guidelines. Gray areas versus red lines. So even when we contrast the fluid nature of continuous clinical assessment with objective safety limits, sure, there's no single bright line rule. However, if you look across hospital protocols, clinical research, and legal medical references, they all converge on some very clear breaking points. There is a consensus. There's a specific point where the medical community universally agrees that a vacuum extraction attempt has failed and the procedure must be immediately abandoned for an emergency C-section. It's that critical point where the risk of continuing vastly outweighs the risk of surgical intervention.
Section 2. The absolute limits. The rule of threes.
In the delivery room, these absolute limits are often referred to as the rule of threes. The very first crucial benchmark is a maximum of 2 to 3 cup detachments. Now, in the delivery room, you'll commonly hear these called pop-offs. This happens when the vacuum cup actually loses its suction on the infant's head and literally pops off. According to sources like the National Institutes of Health stat pearls, as well as legal medical standards from Powis Law, if that cup detaches 2 to 3 times, that is a red line. Reapplying it again and again drastically spikes the risk of severe trauma to the infant's scalp and skull.
Our second benchmark is the number of actual pulls. Protocols strictly cap this at a maximum of 3 to 4 traction efforts. That means 3 to 4 attempts to pull during a contraction. But there's a really vital detail attached to this. If there is no descent, meaning the baby doesn't move down the birth canal at all, on the very first pull, the attempts have to stop immediately. You don't get 3 more tries if that first one proves the baby simply cannot descend.
Finally, we have to bring the clock into the equation. The third limit is time. The maximum total vacuum application time is generally 15 to 20 minutes. Some wider guidelines, like those found in stat pearls, cap the absolute maximum at 30 minutes. You just cannot leave a vacuum suction to a fetal head indefinitely. Prolonged pressure creates localized swelling, it restricts blood flow, and frankly, it invites a whole host of catastrophic complications.
Section 3. The medical risks. The cost of pushing past limits.
We really have to understand the true cost of pushing past these established limits. When those numbers we just talked about, the 3 pop-offs, the 4 pulls, the 20 minutes, when those are ignored, the physical toll is incredibly severe for both the baby and the mother. On the neonatal side, we see a sharp rise in conditions like cephalohematoma, which is bleeding beneath the scalp membrane. Even more terrifying is a subgaleal hemorrhage. That's a life-threatening emergency where bleeding occurs in the subgaleal space, leading to massive blood loss for a newborn. And of course, intracranial hemorrhage, which is actual bleeding inside the brain itself. For the mother, repeated, forceful pulls drastically increase the likelihood of severe 3rd and 4th degree perineal tears, not to mention compounded maternal blood loss and hemorrhage. The physical cost is just staggering.
But honestly, perhaps the most devastating risk is HIE, or hypoxic ischemic encephalopathy. This is brain dysfunction caused by oxygen deprivation. And why does this happen in these scenarios? Because time is oxygen.
When a practitioner spends 30, 40, or 45 minutes repeatedly trying to force a failed vacuum delivery, they're actively delaying a necessary emergency C-section. That delay directly deprives the infant of oxygen during a period of intense fetal distress. So, understanding these thresholds isn't just about knowing medical trivia, it is absolutely vital for patient advocacy. Knowing when that clock should have stopped can literally be the difference between a healthy baby and a lifetime of severe neurological injury.
Section 4. The sequential danger. The ultimate contraindication.
This leads us to a specific scenario with the highest warning of all: sequential instrument use. Using a single instrument, like just a vacuum or just forceps, is one thing. But when a physician tries the vacuum, fails, and then reaches for the forceps to try again, well, according to ACOG Practice Bulletin number 219, this is highly discouraged. It's an ultimate contraindication. Switching between vacuum extractors and forceps drastically elevates the risk of compounding trauma on the infant's brain and skull. Think about it. You're taking a baby that has already endured the extreme stress and suction of a failed vacuum and immediately subjecting them to the crushing force of metal tongs. The rates of intracranial hemorrhage and severe neonatal brain injury absolutely skyrocket in sequential use.
Section 5. Knowing when to stop. Abandoning is not failing.
This brings us to our final and really our most important point today. We have to understand that abandoning a procedure is not the same as failing. Medical literature, like the guidelines from the OBG Project, summarizes this perfectly. A safe operative delivery requires continuous clinical reassessment, yes, but more importantly, it requires the physician's absolute willingness to abandon the procedure if progress stalls. It requires recognizing those red lines, the pop-offs, the pulls, the clock, and crucially, none of this is safe without the immediate availability of an emergency C-section. A vacuum delivery should never even be attempted if a surgical team isn't standing by, ready to jump in the exact second those thresholds are crossed.
So, I want to leave you with this to consider. In a medical culture that often praises persistence and pushing through, we really need to reframe how we view the delivery room. If crossing these clinical thresholds isn't a medical triumph, but rather a direct path to profound danger and injury, shouldn't abandoning a stalled vacuum delivery at the exact right time be viewed as a life-saving success? Recognizing the limit isn't a failure to deliver, it's the exact intervention required to protect 2 lives. Keep this in mind, advocate for those limits, and understand the deep, profound responsibility of knowing exactly when to stop.